Hello and welcome to the Friday Independent Sage briefing. This week, the media has been understandably full of the horrors of war, price rises, energy bills, and inflation. But this pandemic is still not over. We know that effective communication between the government, scientists, and the public is crucially important during a health crisis like this pandemic. Indeed, Independent Sage was set up precisely to communicate directly with the public and to share evidence and protective behaviours. We believe that the upcoming inquiry, which according to reports today may be delayed until 2023, should look at missed opportunities for effective public engagement, which could of course have resulted in less illness and fewer deaths. And to join us in this discussion, we're delighted today to address, ways in which behavioural science is central to managing pandemics. We're delighted to welcome two guests from the Independent Sage Behavioural Advisory Group, Robert West, Professor Emeritus of Health Psychology at University College London, and John Drury, Professor of Social Psychology at Sussex University. And my colleague, Professor Susan Mickey, will lead the discussion. But first, I'm going to hand over to Colin Davis, a guest we've had on before. He's a professor of cognitive psychology and a computational modeler based at Bristol University. And he's going to talk us through some of the actual slightly worrying numbers for this week. Over to you, Colin.
Thank you, Anthony. Hopefully you can see my screen now. So I'd like to start with a question. I think it's always useful when you're looking at data to have a question in mind, because even if you don't succeed in answering that question, it can help to provide a focus for what you're looking at. So the question that I want to consider today is this one: is the pandemic over? And I think, if we're looking at the international perspective, the answer is clearly no. We can see in Hong Kong, for example, that the pandemic is in full swing. In the graph here, you can see that although there were hardly any infections at all in Hong Kong for the last couple of years, and consequently quite low levels of naturally acquired immunity, as they have opened up and Omicron has hit, they've experienced a very large wave of infection, so much greater than any that we've seen in the UK. And unfortunately, the vaccination rate amongst older people in Hong Kong isn't as high as it could be. So this wave has been accompanied by a very high death rate, sadly. So at a global level, the pandemic certainly isn't over. But you might reasonably suggest that the UK is in a rather different position. We certainly have had lots of infection over the last couple of years, and we have a very highly vaccinated population. And the UK government has shifted into a living with COVID phase. And, I suspect that there are many aspects of this phase that might be communicating, at least implicitly, the message that the pandemic is over. So people don't have to isolate now, and they're not paid if they do. You don't have to wear masks, testing's winding down, and so on. And we can see the impact of these policy changes in people's behavior. So in this graph, we can see the proportion of people who are continuing to wear face masks over time. And what you can see is that there's been a significant decline in the last 6 weeks or so. And probably you don't need to see a graph to know that. If you've been in a shop or on a bus, you're probably well aware of that aspect of behavior. And that reduction in mask wearing sends a signal to people. It's suggesting that things have changed and maybe COVID isn't the concern that it was. And another big change in people's behavior has been the reduction in testing, where we've seen a very significant decline over the last couple of months. And some of that presumably reflects the fact that there's less COVID around than there was in January. So people are less likely to require tests. But that's not the whole story, because we can now see that cases are going up, and cases are increasing across all nations, with the steepest increase in Scotland, cases increasing across all regions of England. And we have to keep in mind as well that because of the lower levels of testing, we are probably missing a lot of infections. So there are a couple of surveys that seek to address that issue with testing by looking at random samples of people. And those are the REACT study, which came out yesterday, and the ONS survey, which was published today. And both of those surveys are showing very high levels of prevalence. So this is the ONS survey that you can see, and it shows that the prevalence of COVID in early March was much higher than, for example, in the latter half of last year. And you can also see that prevalence is increasing across all nations, and especially in Northern Ireland, where around 1 in 13 people were infected with COVID in this period covered by the last survey. And we can also break that down by age. And that shows that although primary school children still have the highest rates, those have come down quite a lot in that age group. I think the most salient thing from this graph, though, is that rates are very high across the board, across all age groups. And I think it's really rather concerning to see a prevalence rate of almost 3% in the 70+ age group. So now let's have a look at hospital admissions in the UK. And these have also been going up over the last week. They're going up especially fast in the southwest, where I live. And in Scotland, they now have more COVID patients in hospital than at the peak of the initial Omicron wave in January. And there's been some concern that the increase in hospital admissions might reflect waning immunity, and in particular, a reduced efficacy of the vaccine booster over time. And certainly we can see that the absolute increase has been greatest in the older population, who of course were the first to receive the booster, so presumably will be the first to show waning. But actually, hospitalization rates are going up across all age groups. The percentage increase is not that different across age groups. There are a couple of important things to note, though, about hospital admissions. One of them is that the number of patients in critical care beds over the last couple of months is much lower than it was this time last year. It's actually tracking pre-pandemic 2020 pretty closely. So presumably due to vaccination, COVID is causing less serious illness than it was. And secondly, it's important now to distinguish between patients who are admitted to hospital because they have COVID and who are being treated primarily for COVID, and those where the COVID diagnosis is really incidental to their admission. Now, in the past, it has generally been the case that COVID admissions were due to COVID rather than these incidental with COVID. And that's what we can see there with the green line being above the red line. But the latest data released yesterday are suggesting that incidental admissions are now making up a larger proportion of the total. So, on the one hand, you might see that as good news, suggesting that the increase in COVID admissions doesn't actually reflect that COVID is making more people seriously ill. Although, as infection increases, I think that might start to shift again. On the other hand, though, I think it's really not great news if COVID is circulating in hospitals and healthcare workers are getting infected and people who are already quite ill are catching COVID. But either way, this is more evidence of relatively high levels of prevalence in the community. So we've seen that after this initial decline in infections after the January peak, they're rising now in all regions and all age groups. Why is that? Well, one possibility might be that we have had this change in the dominant variant. So the specific Omicron variant that was responsible for the big wave we had in December and January has now been displaced by a different lineage, which is labeled BA2. That's the red part of that graph. This lineage clearly has an advantage over the originally sequenced Omicron variant in terms of transmissibility and or vaccine escape. Now, the UK Health Security Agency has said that they think that BA2 isn't associated with a more severe disease than the original Omicron, so that's good. But maybe the shift in the dominant variant could explain partly the increase in cases. Having said that, the transition, you can see, has been taking place pretty gradually over the last couple of months. So it's not obvious why that should have led to this kind of quite rapid shift in the number of cases, switching from a steady decline back to a state of growth. But of course, the other factor that may well explain the increase in both cases and hospitalizations is a change in behavior. So changes like those I mentioned earlier, the decrease in testing, the reduction in mask wearing, more indoor mixing, and so on. So as we change our behavior, and then those changes are further reinforced through social influence, there are simply more opportunities for the virus to spread throughout the community. So to summarize then, we're seeing a return to an increase in cases and hospitalizations, and factors like waning immunity and a new lineage of Omicron may have contributed to that, but it seems likely that changes in behavior are playing a particularly important role. And I think for that reason, it's really important what signals we send to each other in our daily interactions, and also what signals the government is sending us in its official communications and its policy announcements. And finally, let me just return to this question I started with. So, is the pandemic over? And this, I think this is an interesting question in that, of course, some people will say, well, cases are going up again, and that shows that the pandemic is not over. But then again, other people will say, well, what it means for the pandemic to be over isn't that we don't have cases anymore, but rather that cases aren't so serious and they're less likely to lead to hospitalization. And personally, I think this is not a question that can be decided by the government or by scientists, but rather one that the public at large has to decide. So just for fun, I ran a Twitter poll last night. Yes, can you see my screen? We had quite a few votes there, and overwhelmingly, people in this poll said that they thought the pandemic is not over. Now, I'm not suggesting this is a representative sample, of course. But one thing I do wonder is whether there may have been more people saying that the pandemic was over a couple of weeks ago. What I really suspect is that we're not going to see a straight line here, but rather a kind of oscillating cycle where people tip towards saying, okay, now it's over, and then they start to mix more, and we get an increase in cases and the other consequences, and then people shift back to saying, okay, well, maybe actually it's not over just yet. And it looks to me that right now we are at the onset of that part of the cycle where people are reminded that actually this process is going to take some time. And with that, I shall hand over to Susan.
Thank you very much, Colin. Well, behaviour is at the heart of causing and sustaining pandemics, but also at the heart of suppressing and ending them. The World Health Organization's chief scientist, Dr. Soumya Swaminathan, said last year, everyone paid the price for not having social and behavioural considerations come into policymaking early enough. And this year, WHO's Director General said, we have the responsibility of creating systems and environments that are informed by behavioural science. Independent Sage has a behavioural science advisory group of 7 experts who have over the past 2 years pointed out what government could have done better in its management of COVID-19 had its policies followed behavioural and social science evidence. We believe it's vital that the forthcoming inquiry, not so forthcoming as we thought, next year's inquiry, that's being set up by the government should consider this evidence and why it was apparently not heeded by the Westminster government. A report summarising today's session will appear on the Independent Sage website in due course, and we'll let you know when that happens. But today we have 3 members of the behavioural group advising Independent Sage to discuss some lessons to be learned from the behavioural and social sciences for this and future pandemics. Now, there's many topics we could have chosen, but we've limited ourselves to 3. So first of all, how to communicate effectively with the public. Secondly, the support necessary to enable people to protect themselves and others. And thirdly, the importance of community engagement with the UK's diverse communities. So first of all, on the issue of communication, Professor Robert West, if I could come to you. Do you think there was a messaging turning point where things started to lose their clarity and consistency?
Yes, I think there was. In fact, probably most of the people watching this will remember a key turning point was probably when the sort of slogan moved from something that was actionable and clear and motivating to something that was vague and actually very easily mocked. And that was going from stay at home, save lives, protect the NHS, to stay alert. And of course, that was widely mocked and rightly so. And I think the key thing here is that we have to bear in mind what the purpose of communication is. It is to inform, it's to motivate, and it's also to remind. And in order to do that, it has to have certain characteristics. And there's lots and lots of studies, lots of behavioural science that the government could have drawn on this. One of them is around the sources of messages, which need to be trusted and trustworthy. And the message itself needs to be relevant, accurate, clear, consistent, memorable, and actionable. And I'm afraid that particular transition to the main slogan was none of those things.
Thanks. And actually what you've been talking about reminds me of a current phrase that we're hearing a lot, which is we're being told to be cautious. Well, what does cautious mean? We do need behaviourally specific advice. What should we be doing more or less? Where and when and how, etc. So yeah, very good point. So if you could change one thing about messaging, what would it be?
Well, it's very hard to choose, really. But I think what I would if you look at where messaging has failed, and I don't just mean the formal comms campaign which they've run. I mean, a lot of the failures of messaging have actually been nothing to do with that. They've been actually to do with the kind of messaging that's been put out by ministers and politicians as sort of thought leaders. They're really the critical issue, I think, has been one of consistency or lack of it. And what we've seen is a lack of consistency between the words and the actions of ministers. Obviously, we have the famous Cummings affair, and then since then we've had Partygate. Essentially, the politicians who people have been looking to set an example and have been giving out these messages have not done the things themselves that they said we should be doing. That's really important. There's been a lack of consistency between one spokesperson and another. You'll have one minister saying one thing, and then pretty well 5 minutes later in the same program, sometimes you'll have another minister saying something completely different. You've also had lack of consistency even within the same press conference by the same minister. For example, you would have, while he is speaking on script, the Prime Minister saying things that make eminent sense in terms of motivating people to take protective measures. And then when answering questions from the public or journalists, saying something completely different. And so lack of consistency is really critical, and it goes across the board. So if I had to pick something, that would be it. But ultimately, one of the things that it has done, which is we know has had an impact on people's behavior, is it's caused a loss of trust. And there is good evidence that loss of trust has been important in getting people failing to get people to do the protective measures that we need them to do.
Yeah, thank you very much for that. And the issue of trust is so important. We could talk about that, but we're going to now move on to Professor John Drury to talk about the role that providing support to people and communities have played over the last couple of years. So, John, what have been the most important support needs amongst the public during the pandemic?
Well, there were support needs in a number of areas during the pandemic. Two of the most important, and the ones I'm going to talk about, are children's technology needs and the needs of those self-isolating. So on the first of these, it's been estimated that children lost around a third of their learning time due to schools being closed during the pandemic. And when these closures first happened, Independent Sage were among those arguing that all children, but particularly disadvantaged children, should have access to laptops as well as broadband connections at home. Now, as well as helping with learning, free broadband and laptops would have helped children to maintain their social contacts during these stay-at-home orders. So moving on to self-isolation, so those staying at home, either because they're infected or they've been in contact with someone who is, need sufficient financial support in order to do so. It's one of those behaviours where you can't really do it on your own. It's one where you really do need support. And from the beginning, Independent Sage was arguing that equivalent to full pay should be given to those required to self-isolate. So there was no detriment, no cost to self-isolation. But in addition to that, people self-isolating have other needs. And one of the additional things Independent Sage argued for was that some people needed alternative accommodation. I mean, you could, for example, requisition hotels or things like that, particularly for multi-generational families. And another thing is incentives. So something to reward people, encourage people, motivate people more to adhere for the full period. And we know that for some of these practical needs, we know that mutual aid groups stepped in to support people. We know that mutual aid groups did people's shopping and so on. But in fact, mutual aid groups also need support. Some of them need support financially so that they can provide communities with this kind of support that they need.
So these are really good examples of the kind of support, very basic kind of support that's needed. What does the evidence say about the extent to which this support was provided? So yeah, there is a lot of evidence in both of these areas. So talking about children's technology needs first. So if you remember back in 2020, the government did promise laptops, but in October of that year, the Department of Education informed schools in England that their allocation of laptops for disadvantaged children will be cut by around 80%. And we know that one of the results of this is that well-off pupils found home learning particularly challenging, precisely because of this lack of technology and lack of sufficient internet in their homes. I mean, I've got a colleague in my department at Sussex who's been researching that and shown that very clearly. Now, this has led to gaps in attainment. So you're seeing an increased gap in attainment between these poorer children and children that are better off, that can be traced precisely to this lack of support. Now, on self-isolation, if you remember, back in autumn, it wasn't until autumn 2020 that the government introduced some money for people who were self-isolating. It was for people on low incomes. It was £500 for the period of 10 days. £500 for 10 days is less than the minimum wage. And the other thing to point out about this is that 2/3 of those applying for this fund were turned down. So, you know, on those measures, this form of support didn't actually meet people's needs. It wasn't enough support. And in addition, the same month that the government introduced this kind of carrot, this reward of payment, they introduced a stick in the form of a fine for up to £10,000 for failure to self-isolate for the full period, at least in England. And if you look at the research in other countries, you'll find that, well, most other countries
do have a fine for people not fully self-isolating, but the UK's maximum fine was larger than that of most other countries. And why this matters, the large fine in relation to the small amount of support, is it creates a clear risk of deterring people from coming forward, either getting tested or reporting their results. So all those people are kind of outside the system. And it's worth noting, if you look at comparable countries, I mean, Germany does have a large fine, but Germany provides workers with sick pay of equivalent to 100% of the wage. And France offers nearly 100% of the wage as well. And if you look at the evidence, so what happened given this shortfall, what did it mean in terms of how people behaved? Now, there's plenty of evidence now of the effect of this on adherence. Now, we know that across the pandemic, self-isolation was the one behaviour that lagged behind all the others, whether it's wearing masks or distancing or hand washing. Very high levels of adherence to all those behaviours, relatively low for self-isolation throughout the pandemic, less than 50%. And then if you look at why, and there's research evidence on this too, and this research from multiple sources shows that one of the reasons why it's low is financial reasons. Not the only reason, but it is a major reason. People are saying that they can't afford it. And then if you look at the demographics, who is it that isn't self-isolating? It tends to be the poorer people. And the second reason amongst those that seem to matter is practical. People are often going out to go shopping and so on. So again, it's that practical support just isn't there. So I would say that given the centrality of this, given the centrality of self-isolation to a pandemic response, this is perhaps the biggest hole in the system. If there's a leaky bucket, this is the biggest leak in the whole bucket.
Yeah, and I'm glad you talked about other countries. But actually, if you go beyond Europe and to countries, even those with comparatively very few resources, such as Kerala, India, Vietnam and Southeast Asia, countries in Latin America, Cuba, etc., they did so much more in terms of supporting than we did, and real lessons to be learned. So thinking about the forthcoming inquiry, finally, and briefly, what lessons do you think need to be drawn from this experience?
Well, I think there are 4 lessons. And first, if we talk about needs for support, we need to understand what those needs are. And I think that means listening, consulting with communities on what their support needs are. I think sometimes the government would have fines and small amounts of support, not realising what the needs are. They're a bit cut off from people's needs. The second thing is, Robert talked just now about trust. In fact, there's a further benefit to being supportive, which is when you're supportive, it actually develops the relationship and it develops trust. So it could produce a better relationship between the public and the authorities and better engagement with some of the mitigation measures. But insufficient support has further consequences, and some of the measures introduced ended up being seen as a bit divisive. There were all these debates around lockdown or stay-at-home orders, but the reason that they were divisive was precisely because people were not given enough support, or at least some people were not given enough support to carry them out, so they didn't have enough support to stay home. So therefore, lockdown was something which was much more difficult for some people than others. And the final point is that these forms of support need to operate on multiple levels. It's not just individuals that need support, it's not only families, it's whole communities. We saw the arguments of Andy Burnham about the way that Greater Manchester was disadvantaged, but it's also local groups, local mutual aid groups can be supported because they have relationships with individuals in their communities that need support.
Thank you, John. Well, that's very powerful, including the importance of engaging communities. So finally, can I turn to you, Professor Stephen Reicher, to think about what's the evidence for how important it is to have communities engaged during a pandemic?
So can I start by saying that I think one of the corollaries of where you began, that the importance of behavioural science, is that actually, if you get the behavioural science wrong, you can do a lot of harm. And I think the clearest example of that we saw at the beginning of the pandemic with the notion of behavioural fatigue, this notion that people are so weak, they won't be able to put up with any measures against COVID. And so in that fateful week, about almost exactly 2 years ago, in the middle of March, we delayed implementing measures. And it's been estimated, Neil Ferguson, for instance, estimated that doubled the death rate. It led to about 25,000 deaths. And the problem with the notion of behavioural fatigue, and it reflects something wider in the government response, is that they did not understand the notion of community. They thought that in a crisis, individuals will crack, won't be able to do the right thing. Actually, the evidence of research on emergencies for about the last 30 or 40 years has been that actually what happens in emergencies is people come together. That common experience, that common fate leads to a sense of common identity. And that sense of me turning to we and us is critical. So a number of studies show that very early on in the UK, a study showed that the major factor in adherence was people wanting to come out of it together, not as an individual, as a community. Big international study, 66 countries, 44,000 people, showed that the major factor in explaining adherence was a sense of belonging to a national community. And similarly, work shows that feeling a member of a local community was very important in terms of adherence. So the first and most important point is that when you shift from I to we, to a sense of community and concern for the community, it increases adherence. It also increases resilience, because people feeling part of a community feel not only they will support others, but they will be supported by others. It leads to practical help, the emergence of those mutual aid groups that John talked about. So we saw about 14 million people involved in mutual aid, 5,000 groups up and down the country. And last but not least, actually that sense of connection is really good, both for our physical and our mental health. So creating community, nurturing community, thinking in terms of we, not I, is absolutely central to the pandemic response. And if you get it wrong, you create as much harm as you do by failing on your test and trace system, your PPE, and whatever else.
Thanks. And following on from that, finally, how do we build communities and make them more inclusive? Because this is an incredibly important issue, again, to bring to the attention of the forthcoming inquiry.
Well, I think your question is a very good one, because I think it's important to stress that community has to be inclusive. If you get an inclusive sense of we, it can be very powerful. If you divide into we and they and start blaming others for the problem, actually it can be catastrophic. And we've seen historically in other pandemics, it can lead to huge levels of collective hate. In the Black Death, for instance, Jewish communities were blamed for the pandemic, and it led to 600 Jewish communities being destroyed, 2,000 Jewish people being burnt in one day in Strasbourg in 1381. So creating an inclusive sense of community is really important. And I think the answer to your question, in a sense, takes us full circle, because it goes back to those two other elements we've been talking about, which is communication and which is support. In terms of communication, I think one of the problems is increasingly the government has gone away from talking about communities, about inclusive reopening, about being as concerned for the vulnerable as we are for ourselves, to talking about personal responsibility. It's up to you whether you want to wear a mask or not to protect yourself. No, we may wear masks to protect each other, to protect the community. So in a whole series of ways, the communications have individualized things. And the second thing, and this takes me to my favorite quote of the whole pandemic from Bonnie Henry, who was the chief medical officer in British Columbia. She said, "We're all in the same storm, but we're not necessarily in the same boats. And you're only going to get a shared identity if people can experience the pandemic to some extent in the same way. If it hits some people and not others, if some people are fine and can sit in their gardens outside and other people are told that they can't go outside, you'll begin to divide people. So you've got to give people the resources so that they can abide by the measures that are necessary to deal with the pandemic. And you fail to do that, and you fragment people. And then the people who can't go along with the measures, who are forced to go out. And another really important study early on, it showed that right at the start in the lockdown 2 years ago, that poor people and ethnic minorities were 3 to 6 times more likely to break lockdown. Not because they weren't motivated to do so, their motivation was exactly the same, so that they couldn't afford to stay at home and put food on the table. But if they're forced to go out, then other people start pointing the finger and blaming them and saying, you're spreading disease, and you get that division. So we needed a government which saw as a community, which talked to us as a community, but above all gave us the material support so we could all be in the same boat, or at the very minimum that all our boats were at least seaworthy, and they weren't. And that's one of the tragedies of the pandemic.
Yeah. Thank you, Steve, and thank you, John and Robert. These have been really useful points that you've made. As I said at the beginning, we've only selected 3 issues to talk about. There are, probably hundreds, but certainly many, many more that we would want to get the attention of an inquiry. The terms of the reference have been released now, but I do hope the inquiry has a breadth of perspective and is open to listening to these really, really key issues if we are to save the population from being so harmed as they have been over this last 2 years. So with that, thank you all, and back to Anthony.
Thank you very much, Susan. Actually, I just add one postscript to this very useful discussion is about structures for community engagement. One of the reasons I think the poorer countries in East Asia particularly did so well was because they were accustomed to having community health workers, community health volunteers. And if you look at, for example, in South Korea, they mobilized very quickly to their hotspots to do testing, tracing with large numbers of community workers. In China, they brought in 9,000 community health workers within a week to Wuhan, which had a population of 11 million. We had, I believe, under 300 tracers for 55 million people. And so we didn't mobilize. We're not used to that. And that's something that we have to think about if you're going to make a rapid response in future in pandemics. So, our individualist approach to medicine is something that we have to revise, in my view. Anyway, that's not my role to be a commentator today. So we'll move on, and we're going to go to the press and public for questions. And our very first question will come from Claire Simpson. Claire Simpson, the floor is yours if you put your camera on. And Claire.
Hi, I was wondering why cases have been rising so rapidly in Scotland compared to England, particularly when we do have more mitigation still in place.
Thank you, Claire. That's a very important question. Colin did address it a bit, but I'm going to come back to Colin and then maybe go to Steve Riker because he lives in Scotland and he knows quite a bit about Scottish behaviour. So let's go. Colin, do you have any thoughts on this?
Well, it's always very difficult to know how to explain particular outbreaks in different spots, and whether you should be looking for something systematic, or perhaps there could be essentially random factors which can then be can explode because of exponential growth. I mean, one thing I would say is that yes, the hospitalization levels are very high in Scotland, but it's not unique in the UK in terms of seeing an increase in prevalence. And we probably shouldn't be looking for a factor like latitude, weather, because actually we see in England it's actually in the southern regions that to the extent there's any difference that we have higher levels of prevalence. One thing that is quite unusual about Scotland, I don't entirely understand it, is that there we're seeing the biggest increases in prevalence amongst younger children. Now, I believe, maybe Stephen might be able to confirm this, that there has been a change recently in Scotland with respect to mask wearing requirements in schools. So I'm speculating, but I wonder if that could be a factor. But with all these things, it's going to be either a random factor or immunity or behaviour, and I suspect that behaviour will have a lot to do with it. So as someone in Scotland, Stephen can probably tell us more.
Steve.
Well, I'm not sure I can. I mean, I saw the behavioural data on Monday in a meeting, and when you look at the behavioural data, actually it looks fairly good. The drops aren't as catastrophic in, say, mask wearing as in England. Of course, people are still being told they have to self-isolate if they are infected. That Scotland is more positive about keeping testing. So in many ways, actually, the behavioural data is not as bad as all that. So I think it's quite difficult to explain it simply in behavioural terms. So it could be some, I mean, as you say, it could be some of the other factors. It could be waning immunity. It could, although we have no evidence for this, be a different mix of variants. One really interesting thing, though, is that in Scotland, one of the biggest differences in the data in Scotland is that level of trust in the Scottish government is about twice as high as in the UK government. It's still about 70% or so, and still it shows that most people think the right thing to do is to do what the Scottish government asks you to do. And what that suggests is that while, and I certainly wouldn't want to undermine anything that was said earlier about the importance of trust, and I think trust is particularly important around things like vaccination, where you have to trust people to take a vaccine, is that in many ways during this pandemic, a lot of the adherence has been despite and not because of the government. So in England, people might have lost trust in the government, but they still adhered precisely because they thought it was the right thing to do. And many of the people who were most angry at Cummings were most likely then to adhere. Now, it's not a good situation in the sense that you don't want to be in a position where people are adhering despite the government and the government isn't leading. But it does make a really fundamental point, I think, which is, I think, in many ways, the most fundamental point about the behavioural position, which is that the government's argument all the way through, and behavioural fatigue was part of it, is the people are the problem, okay? Government would like to do things that can't because of the weakness of the public. Actually, this pandemic has been almost exactly the other way around. What we've seen is remarkable levels of adherence by the public, despite a government which has communicated badly, not given them support and individualized them. So a key point is the people are the solution. And you've got to know how to mobilize that solution. And if you treat people as the problem, as the enemy, you're never going to be able to do that.
Does anyone know about vaccination? Were boosters rolled out earlier in Scotland than in England, or was uptake earlier? Because if that was the case, then maybe waning immunity might be higher in Scotland because they got their jabs earlier. I don't know. No one knows that. We need to look back at the data. Where's Christina when you need her? But anyway, okay, well, look, that's very important. Let's go on to our next question. And the next question is from Karim Malik. Karim.
Yeah, good afternoon. And firstly, thank you very much to Independent Sage for all the great work over the past 2 years. So my question is related to this, the potential waning of immunity. Will fourth jabs be necessary? And if so, when?
That's a great question. Thank you so much. And a tricky one to answer, but I'm going to give it to Professor Danny Altman, who is an immunologist, and we'll have some thoughts on this to start with.
Yeah, a brief, simple answer. I think obviously we are seeing an enormous number of breakthrough infections and reinfections, and that is to do with immune waning and the evasiveness of Omicron. And we can go the way that others have gone, and we are, as of this week, heading into a schedule for fourth boosts, initially for the elderly and the immunosuppressed, and then hopefully after that, beyond that, as some other countries have done. We do need it. Whether you ask me as an immunologist, is this state-of-the-art vaccinology or immunology to be reboosting every few months because you haven't really thought through a durable vaccine program? That's another question altogether.
Is there an element of original sin? Do you believe in original sin? That is, that if you're immunized with one type initially, the more you give boosters, the less effective they become. Is that a possibility, Danny?
I'll try and answer you in less than 30 seconds, because I could write a whole PhD thesis on this. But the answer is that we've now got a planet with a whole menagerie of different histories of COVID and vaccine record, and we're all responding differently to everything we see. And some of that immunity is very compromised, and some isn't.
Okay, thank you. Let's go to Steve Griffin, our virologist.
Thanks, and I completely agree with Danny. I think the need for booster programs, which are, let's face it, usually done in response to an emergency situation, the need for booster programs is driven by the prevalence of the virus. And, you know, we had a session a few weeks ago about the fact that this virus is going to continue to come at us in surges and in waves, and when new variants arise, that's a new challenge. So we can't really approach this as a steady state unless we can get control of the level of infection in this country. And at the moment, the vaccines are having to do that job pretty much on their own, supported by the compliance and behaviors that we've heard about. So the reason that waning antibodies are an issue is because there's a lot of virus around. The reason that we have a lot of breakthrough infections is because there's a lot of virus around. And we know that we can control that by other means, but it's been a policy decision to not do that anymore. So the need for boosters, the answer is the need for boosters is driven by the level of virus. So get one in control and you won't need to boost as often. And it may give us time to do, as Danny suggests, is to make a state-of-the-art vaccination program without too much haste involved.
So Steve, to answer Karim's question, when do you think this is going to happen?
Well, as Danny said, it's happening shortly, I think, for people who were in the more vulnerable groups who were boosted sort of in the first round of boosters. So the clinically extremely vulnerable group of about 500,000 people, and people over 75, Danny, I can't remember, because they are more likely to experience what we might term immune senescence, and the levels of antibodies that they're making over time have just gone down. They will come back up. They will be protected in the short term.
Yeah.
And I think that's an important thing. But how long you can continue to do this, that's quite another question.
And Zubaida, will vulnerable groups who have been reluctant to get vaccinated comply with a fourth vaccine?
Well, I mean, we know that vaccine hesitancy has been an issue throughout. To what extent that's been dealt with, I think it's difficult. There's been some movement with vaccine hesitancy, but I'm not convinced it's been comprehensive. Anthony, what I'm more concerned about is it's not just about waning, it's the combination of waning and exposure. And it's what Steve Reiches was saying before about the fact that while we're facing the same storm, we're not in the same boat. And we've known from the outset that those people who are more likely to live in overcrowded housing, and that includes some Black and ethnic minority groups, and that includes people living in deprived areas, they are much more likely to be exposed to the virus. Now, if we have high levels of the virus circulating, combined with waning of the vaccinations, combined with people in those houses more likely to be on the front line, then it means that those people are much more vulnerable. And I think to this day, we haven't addressed that at all, as well as issues around self-isolation support. Newham was the only council, I think, in this country, who actually dealt with the issue of overcrowding and self-isolation by providing assisted accommodation, if you like, by supporting accommodation elsewhere so that people could protect themselves in overcrowded housing.
Okay, thanks. A quick comment from Steve. Steve
Thanks,
Griffin.
Anthony. Yeah, just one important point to make, Karim, is that these boosters are designed primarily because we are losing the ability to protect ourselves from being infected. It's important to point out that what the vaccines have done is disconnect this very stark relationship between being infected and getting severe disease, especially amongst vulnerable populations. And you can see the difference there from some of the data that Colin showed earlier, if you compare Hong Kong with the United Kingdom, okay? And we know that we've had lots of infection, we've had lots of vaccines. I think the story is that it's mainly the vaccines that have given us that protection. The problem is that not everybody makes that ideal response to a vaccine. Not everybody has a vaccine. There's still something like 18 million people in the country that haven't had one. And so until we reach that point where we can say safely that the level of virus is so low that the number of people that haven't made that good response to a vaccine isn't going to cause us too many problems, then we have to keep boosting to prevent those infections happening, because the more infections, the more chance of a small chance of something happening. This is the major issue with having high prevalence, and it's really something that drives us to get complete vaccination across the board in all ages as quickly as possible.
Thanks very much. Okay, we got 3 more questions I want to get in. So let's move on to Peter English. Peter, the floor is yours.
Good afternoon. My wife has recurrent cancer with one of the lobes of her lungs collapsed due to metastases. She's had her 4 doses of vaccine, but what I'm interested in is the relatively mild disease that we get after vaccination. Is that could be really serious for somebody like her, and how much protection can somebody like that expect from 4 doses of vaccine, and will they need to keep topping it up to prevent the minor infection for which you need high circulating serum antibodies?
Thank you, Peter. I'm sorry to hear this news, but I'm going to hand that over to Helen Salisbury, who is our GP expert.
Hello. I think it's really difficult to know, Peter, what will happen for your wife if she gets infected. I think we are noticing that most older people do need to keep topping up, and particularly if her ability to respond well to the vaccine is compromised. I don't know where she is in terms of chemotherapy or things that might affect her response to being vaccinated. And it's all how ill people might get when they have an infection very much depends on what their starting point is. So on the whole, people who are frail to start with, that little bit more at risk, even if they have an illness which for most people would not be severe. So for most people, having COVID when they've had 4 jabs, they're very unlikely to be very ill, but it really depends on how fragile, what sort of reserve she's got, what her lung functions like. So I think in your situation, I would be pressing to find out when her next dose might be due, but also still being, unfortunately, having to be really quite careful about exposure, because there are a lot of people out there still with COVID. And I think this is, we come back to the sense that we were talking about earlier with I read about something recently in Scotland where they're asking people who are vulnerable to wear some sort of badge to say they're vulnerable. I think this is awful. We should be looking after everybody in the community and setting things up so that we're all as safe as we can be, which I think is about not just asking people who are vulnerable to stay home and avoid other people, but to ask everybody to be helping protect people around them by wearing masks in enclosed places, by sorting out those enclosed spaces with air filtration and all the things we need to make them safe. So I'm really sorry, Peter. I wish I could be more reassuring for you, but I don't think I can be. And I would say that, your wife probably should have to be boosted as soon as she can be. I don't know whether my immunology and virology friends have other things to add to that. Steve.
No, I'm going to move on because I've got 2 more questions, and I'd like to get, because before I come to Paul O'Dear, I've got a question coming on Twitter saying I'd like to understand the outlook for the BA2 variant given the fact that we've abandoned so many controls. And I wonder, I think that's one for Professor Aris Katsarakis from Oxford, who is an evolutionary biologist and understands all about variants. So Aris.
Sure, yeah. I mean, there is a lot of uncertainty, so I'm going to have to begin with that for BA2. It does seem to be more successful. It's dominating in various parts of the world. In some parts of the world, it's also associated with elevated hospitalizations and deaths, and in others it isn't. And it's quite difficult to disentangle how much of this BA2-driven wave is due to intrinsic transmissibility or an ability to overcome prior infection. For example, the very high mortality in Hong Kong, which seems to be driven by BA2, is probably largely due to under-vaccination of the elderly rather than some intrinsic property of the virus. It does seem to be perhaps more likely to reinfect previously infected individuals, and there are lots of anecdotal reports in the UK of people being infected twice since the beginning of the Omicron wave, and how much of that might be due to a BA2 infection being able to sit on top of a normal Omicron is an open question and something that's to be determined, and could in part be a component of the resurgence of cases, but it's very, very early to be definitive about the extent to which the genetics of the virus might be driving this.
Are there any other nasty variants hovering around? I see some stuff on Twitter about a Delta Omicron hybrid nasty that's floating. Is this something that worries you?
So there has been a description of a recombinant between a Delta backbone and an Omicron spike. There were some earlier reports about a month ago that proved to be a false alarm. It was a laboratory artifact. This does look to be a genuine, real biological sequence, so it's a true recombinant between these two variants. Numbers are very small. There are a couple of very, very small clusters, and whether this is going to become an important variant or not is very, very early to say. But given how nasty Delta and Omicron have been, obviously it's one to monitor very closely without having a very strong prior in it necessarily being any worse than either of the two on their own.
Thank you very much. Well, we've got one more question, and it's from Polo Deer.
Hi, thanks very much to Independent Sage to start with. What you're doing is absolutely fantastic. My question is, could the panel comment a little bit on viral load? I'm thinking of the intensity of the virus in the environment and then how much you need to absorb of it to actually become infected. And I find it very useful myself just thinking in these sort of terms when I'm looking at somewhere, should I go in there, should I do this or that? And particularly since we know now that it's an aerosol. Thank you.
Thank you. Very good question. I think I'll go straight to Steve, our resident virologist.
Okay, thank you. That's a really easy one to answer. So we don't know really, Paul. It's difficult. There have been human challenge studies that were done and reported on, but most of those were done with the original strain of the virus that came out of Wuhan. And so they have worked out a sort of experimental infectious dose, if you like, for those viruses for fairly young, because they wouldn't recruit older people or vulnerable people to these sorts of trials, and well, reasonably fit young individuals, and their resilience, of course, plays a part in them not getting severe disease. So to establish an infection is one thing, but any infection process is a balance between the individual concerned, so our immune status, and the virus itself and the intrinsic properties of that. And as you rightly say, it seems to be predominantly aerosol driven. And then also our environment, so the humidity in the air, whether we're taking medication and all sorts of things. So actually the establishment of infection is a fairly random stochastic event that depends on multiple factors. And that's why in a household, for example, we have something that we measure called the secondary attack rate. That is that if an infected person becomes infected, how likely are they to pass that on? Now, what we've seen with sequential variants such as Delta and Omicron is that they have become more likely not always in the same scenarios, but more likely under certain circumstances to transmit that infection on to somebody. But it's really hard to make real comparisons because, of course, we've had differences in behavior, differences in mitigations, differences in our awareness and testing, and all the rest of it like that. So the important thing to remember is that ideally someone who has been vaccinated, if they're wearing a mask as well, are going to be producing less virus. And if you are wearing a tightly fitted filtering mask, then you will breathe in less virus. And of course, ventilation is key, and filtration units can help reduce the levels of virus load in the air. That has been established. There are some studies just out this week that are showing how really effective mask wearing can be at reducing cases in American schools, for example. So I think it just comes down to, again, something that we've been saying for a very long time: minimize your exposure to heavily breathed and recycled air, and minimize your close exposure to people that you know to be infected. So again, as we said on this briefing several times, we think that the isolation rules should be maintained and people should be wearing masks. So yeah, I know I can't answer the question specifically. It's a dynamic process, but we still need to keep safe and keep cautious in all these circumstances.
Thanks, Steve. Thanks to everyone. We're going to have to wrap up there. Thank you, especially to our guests today, Colin, John, and Robert. And thank you, as always, to all the Independent Sage panel for their time and their continued hard work. We intend to continue to provide this popular forum on a weekly basis so that we can monitor the pandemic, the trends, and especially answer your questions. So thank you very much for joining, and we'll see you all next week.
Cheers.